welcome to another week of Antidotes Stories in Medicine. This is your host, Christine. I am so glad to be back with you all. I know it has been a little bit of time. May is always a very crazy month for me. There are so many family birthdays, of course, Mother's Day, and then this year, my boyfriend graduated from college again, and I'm so proud of him, and we were taking the time to really enjoy celebrating his achievements. So podcasting got put on the back burner a little bit. But I really love going to a graduation. It's just so exciting to see everyone and all of the family members that are there supporting them. It's always wonderful to see everyone all dressed up in their regalia and celebrating all the institutions of learning and academia. I just really love graduation. So to everyone out there that has graduated, all the new nurses, all the new doctors, all the new paramedics, physician's assistants, respiratory therapists, everybody, congratulations. Truly enjoy it. You guys earned it. Most of you in the medical field are going to be sitting for boards soon, but just take a few moments to celebrate what you've accomplished, because obviously it's a very long road, and no matter the degree that you obtained, it is something to be shared and enjoyed, and just really savor that moment and cherish, what you were able to do before you start studying again. I know for me, when I finished my NP, I had probably one of the roughest years of my life. And I felt so bad because I was so busy working and going to clinicals and class full time that I barely saw my dog. And I came home, and not that I'm condoning a lot of drinking, but I had a bottle of champagne and I was walking around in my giant master's robe feeling kind of like Harry Potter, wouldn't take it off, with high heels on, drinking champagne from the bottle and going to my black lab. I'm sorry, I was such a bad dog mom. I did this for us. So 3 years later, I still remember that, and I think he's forgiven me. Everyone just really enjoy those fun moments and the celebrations, because you certainly earned it. And if you have a job already, if you're going to be getting one soon, I know there is so much anxiety about, will I be ready as a new grad? Will I know enough? Will I ever know enough? I feel like I don't know everything, and that's okay. Just remember that in medicine, you're never going to know everything. Even the smartest people in the world, the smartest physicians, the specialists, they don't know everything. But the people that are really astounding providers know when they don't know something. They know when to look it up. They know how to look it up, and they know when to ask for help and who to ask for help. So be humble, be compassionate, be kind, and look out for the patient, advocate for your patient, and always just ask for help when you don't know something, and have the humility to ask someone who maybe has a different licensure than your own. New doctors, you can learn so much from paramedics and nurses. New physician's assistants, you can learn things from respiratory therapists. You can learn things from CNAs. You can learn things from techs. Someone who is experienced in the field has knowledge that they have attained over the years that you may not have. And so that collaboration will provide better patient care. It'll make you a better provider in whatever realm you're practicing in. So be kind to your coworkers, be kind to yourselves, and most of all, remember why you got into this, because burnout's real and we want to avoid that as much as we can. Just because someone was rude to you in your training doesn't mean you have to be rude to the next generation. So remember that, and please enjoy what you've done and continue on learning. That is so important in this career, is to continually stay up to date on what's going on. This is just the beginning of all the learning. I think I fully began to understand the things that were taught in my courses once I got into clinical practice. So I am sure that will be the case for all of you new grads, and I'm so excited to welcome you all into the profession, and particularly Angela, one of our early guests on. She graduated with her NP this year too. So I'm so happy to have another FNP in this world. I know there's a bunch out there. So congratulations to everyone. You really deserved it. So sappiness aside, we are going to be going on to this week's episode. So this week's episode was actually recorded on location at Inova Loudoun. It was a new thing for the podcast to be invited to a hospital and record there. So it's going to sound a little bit different, but I hope you like it. And we might as well just get right to it. Here we go. All right, so this week we are actually on location at Inova Loudoun with two awesome people, and I'm so excited to get invited to a hospital. This is really crazy for a podcast to be doing some on-scene reporting. But thank you so much to Inova, and specifically Ray and Amanda, for having me here and letting me speak with them about music therapy. So Ray is a music therapist and Amanda is a clinical nurse specialist. So welcome to the podcast.
Thanks for having us.
Absolutely. Thanks for coming out.
So in the podcast, I'm always talking to people that have very different roles in medicine. I'm sure there are a lot of people that don't recognize what a music therapist is or what a clinical nurse specialist is. So does one of you want to start with explaining a little bit about what your role is just in general?
Sure. Okay, Ray's letting me go first. Thank you, Ray.
Sure.
So as Christine said, I am a clinical nurse specialist. Been working in that role for close to 5 years. I would say probably the number one misconception in healthcare is that a clinical nurse specialist is a nurse educator. So we are two very different roles. A clinical nurse specialist is one of the 4 types of advanced practice nurses. So I think the public is probably most familiar with the nurse practitioner role. That's what most people sort of know. Also nurse anesthetists and nurse midwives. So the CNS, that's our abbreviation. We are one of the 4 types of APRNs. So depending on the state that you reside in, there is some variation in practice depending on whether you have prescriptive authority as a CNS or not.
Okay.
So in the state of Virginia, currently right now, the CNS does not have prescriptive authority. We register as a CNS under our RN license. So that kind of changes the way the role is utilized in this state in particular. However, fundamentally, the role is really a content expert in a particular area of nursing. So in the acute care setting, in the hospital setting, typically the CNS will support, say, critical care nursing. So they'll be the content expert for critical care. So they'll be the person that writes the policies, that looks at all the new research coming out and, decides how are we going to implement this into practice. Sometimes the CNS will do research, depending on where they work. The other way the CNS role can be utilized out in the community setting is they could be, say, in charge of a diabetes clinic.
Okay.
So it really varies a lot based on the state. But typically in the hospital setting, the CNS will work with an educator and then sometimes with nurse practitioners, and they'll kind of work in a team model. So the NPs will round with the physicians. They'll be a part of that practice. Sometimes the CNSs will be involved in the rounding and offer practice suggestions. But really what is unique about the CNS role and really why I chose it is we are the resource to the nurse. So we're there to help the nursing practice be the best that it can be based on the evidence.
Okay. So I know that CNSs are a little bit more popular like in the middle of the country than they are like on the coasts. And part of podcasting is you get to learn about how medicine works all around the world. And so I know in the UK, there's actually a very awesome listener that's a CNS in the UK. And so she's a clinical nurse specialist in MS. And
wow.
Jenny, I'm going to butcher your description of this. She was explaining it in the Facebook group, but basically kind of what you're saying, but she's a liaison for the patients and helping them manage their care and helping them work with the physicians and understand their disease process. And someone's like, we have those in the United States. And I'm like, they're APRNs, but I don't really know what they do. Because I knew some states they prescribe, because I knew psych CNSs can prescribe sometimes in some states. Do they diagnose in some states?
Yes.
Okay.
Yes. So I was actually just double checking the stats this morning, but I know it in at least 28 states the CNS can prescribe. And then it depends on the state as well, whether they can work independently from a provider. So similar to a nurse practitioner, but I think the difference is the NP really would follow more the medical model, because typically most NPs are working with a provider. They don't always have to, but the CNS is more of a content expert in that area. So like I said, some of them will have that niche area of, I like caring for diabetes patients who have diabetes. So I want to be the expert in diabetes management, and they'll run that clinic and work with an NP and they'll kind of, do that. But yes, out in the Midwest, I noticed that a lot of the center sort of states, were lit up, and that's probably where those clinics are also happening, also maybe out on the reservations and things like that. So it does vary. Now, I will say the CNS does do some education, but we are not trained like an educator where their focus and their program is really how do you educate, the nurses. We do a little bit of education, but it's not our primary role.
I'm sure that's just the tip of the iceberg for everything that all CNSs do, but I think that's a great summation for at least even me that was like, I kind of know they exist and I know they're great. I'm just not sure how they're utilized, especially since I work in outpatient. So Ray, talk about music therapy. How did you get into it? What is a music therapist? Do you just sing Kumbaya all day long? I'm sure it is much more nuanced, evidence-based than that.
Exactly, yeah. So I'm a board-certified music therapist.
Okay.
So what does that mean? So yes, a music therapist is a clinician. So I am a clinician that uses music as a tool to help address patients' needs and such. So a music therapist trains, goes to college to become a music therapist. You can go through a 4-year program and get a degree in music therapy. Most music therapy programs are also part of the music school in universities. So you're taking all the courses as a music major, plus you're learning and working in all the courses in the therapeutic content as well. So once you complete a university program, you then have to do a 1,200-hour internship where you are working with a board-certified music therapist for training and supervision. And then after you complete all of that, you then have to sit for a board certification exam. And then once you pass that exam, you get the certification of a board certified music therapist. So that is what I am. And then I have since also gone and gotten a master's degree in music therapy as well. So as a music therapist, as I was saying, we use music as a tool to work on clinical goals and clinical needs. So we may address things like anxiety. We may address things like pain. We also may address some psychosocial issues where we're using music to help someone deal with coping with being in the hospital or coping with a new diagnosis and such. So all of the work we do as a music therapist is all evidence-based. It's an evidence-based practice, and it's all based on research that has been done. So when I'm using music to help someone, I am generally using live music, playing music in the moment. I play guitar, but music therapists can play any instrument. And the reason I'm using live music as opposed to recorded music is I can tailor the music to the immediate needs of the patient that I'm working with. Mm-hmm. So an example of that is if I am working with someone who's really, really anxious, has a lot of high anxiety, maybe because they have a surgery coming up in the afternoon or just because they're in the hospital. So if I were to go in and put some really soft, soothing music on for them to listen to and a recorded music, it's really hard to go from that anxiety state where they are down to this soothing place that the music is residing. So as a music therapist, I am going to start by matching the music that I am presenting to where they are in the moment. So I may play something that sounds like I'm imagining they're feeling in that moment. Mm-hmm. And we're kind of like in training together. And then I will slowly manipulate and change the music to bring them to another place, to a more relaxed place.
That makes sense. I mean, it's just like in nursing or medicine, when we're giving meds, we titrate to effect. You're just titrating the music to effect.
Yes, exactly. And we can do that with pain. We can do it with anxiety. So why music? A couple of things. First of all, we know through research that music is one of the only things that we know that is a multiple brain activity. So what does that mean? So if you're looking at someone's brain and they're speaking, that comes from a very specific part of your brain. If you're hearing, same thing, your fine motor skills, all this, they all come from very specific parts of our brain. If you add a musical element, like singing, for example, or even listening to music, we see multiple parts of our brain firing. Mm-hmm. And we know this by looking at musicians in fMRI machines or simply listening to music. So we can use that to our advantage because we also know that our brains are plastic and there are these neural pathways that can send signals from good parts of our brain to an injured part of our brain. So if someone has a stroke and they lose their ability to speak because they have aphasia, and that affects that part of their brain where your speech comes from, Well, if we add singing, we know other parts of their brain are going to start firing up. And we can use singing to work on getting them their speech back. We can use singing to help someone get their voice back if they had a stroke or if they had a traumatic brain injury. So we know our brains work differently when music is involved. So that's one of the areas why music and therapy and healing and healthcare go together. The other is the inherent elements of music, kind of our bodies work like music works. Everything we do is in rhythm, if you think about it. Mm-hmm. Our heart beats in rhythm. We walk in rhythm. We breathe in rhythm. If the rhythm's off, we're feeling bad. If the rhythm's off in music, the music does not sound good. We want things in our life like harmony. That's a musical term. If we have dissonance in our life, dissonance in music does not sound good. We don't feel good. I like to give the analogy of if there is a 40-piece orchestra playing a beautiful Mozart symphony and one oboe player is out of tune, the entire orchestra is going to sound bad. That's how our bodies work. If our appendix is not good, our entire body's going to feel bad. So that's how music and our bodies work. And music has things like minor chords that make you feel a certain way and major chords. Music has tension and resolve, and we can use that when we're helping someone with pain by getting the tension and resolving it. So there are all these different fascinating elements of how music and healing can go together.
There's been, and again, I have not read these studies in so long, but I remember there were some studies on like Parkinson's and music therapy, because Parkinson's is a movement disorder, but also with a speech disorder, and starting the movement or starting the speech is very difficult. But because, like you said, music, it has a rhythm to it, it's very fluid, it's easier once someone has started to continue doing it. So people will sing their speech and then they can continue to speak and get it out. But it's so hard to where speech is so staccato, continuing to have like a rhythm to singing whatever they're trying to say is much easier for someone. I think it was Parkinson's.
Yeah,
it was so long ago that I read
this.
No,
that is definitely true with Parkinson's. It's a neurologic disorder.
Yeah, music therapists were great for that.
Yeah, so again, the same thing with rhythm and such. So oftentimes when a music therapist is working with someone with Parkinson's, might be working on their gait, because their gait is very off. So we get some rhythm going, and sometimes while they're walking, we might play a song that they love, because we also know that the music that's important to us, we respond to. So, we might play a Nat King Cole song for someone who is of a certain age while they're walking with their walker, and the rhythm is right like this. And it's like, la, da, 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 da. And they start entraining. It's called entrainment. And suddenly they're stepping to the rhythm. Same thing with speech. So that's, there are ways. And a colleague of mine has a Parkinson's choir. A colleague of mine who I work with at a place to be.
That's so cool.
Yeah, we have here at Inova Loudoun, we have a stroke recovery choir.
What?
All people who have had a stroke, and they come together every week and they sing.
They probably sing so much better than I do without having had a stroke.
They really work on music, and they sing, and the singing helps them with their voice and their aphasia. It's also the psychosocial aspect of them all being together.
Yeah,
and they are
so isolating.
They're famous. They performed at the Kennedy Center about a year and a half ago with Renee Fleming, very famous opera singer, as part of an initiative called Sound Health. That's a new initiative with the NIH and the Kennedy Center.
Oh, cool. I'll have to link to it.
Yes. Oh, the choir's name, because it is a great name, they're called Different Strokes for Different Folks. That's the name of the choir. So,
all right. I'm a huge pun fan for anyone that follows the podcast on social media. So Different Strokes for Different Folks. I like that.
Yeah.
Nothing like some medical humor.
It's really an awesome group, and it really speaks to our mission and meeting patients' unique needs and really providing that even after they're hospitalized, offering that to our patients. And, here at Loudoun, we were the first to get it going within the hospital system, and we're really excited that the work we have done here is now spreading out to the other hospitals. So.
And I will also say, and this can maybe even lead into talking about the research.
Yeah, I do want to ask about that.
But, music therapy is a non-pharmacological intervention, and that's the big word here, because we are trying to avoid oftentimes giving more medication for anxiety, more medication for pain. So through our research, we know that a music intervention may be able to help someone reduce their anxiety or reduce pain where we may not have to give as much medication. And certainly in this era of opioid use, it's very important. And, more and more hospitals are, to their credit, bringing in programs like music therapy, art therapy, healing touch, which we have here, all these non-pharmacological ways to help our patients.
Well, and if someone is dancing along to the music that you're playing, you're also incorporating physical therapy and occupational therapy and building strength and balance and building muscle memory. Because I know there are studies that says even if you're not actually doing the movement, but you're imagining movement through dancing or whatever, that actually builds muscle memory and muscle strength as well. So music is so important for that component too. How many music therapists do you have here at Inova Loudoun?
Right. Here at Inova Loudoun, we have 2. I work predominantly with adults, and my colleague here works in pediatrics.
Okay.
So we're pretty much we're here full time throughout the week.
Okay. And how many patients would you see in a week?
Again, it varies. I would say the average on any given day, I will see anywhere between 5 and 8 patients. And again, it varies. And I'm not just, randomly walking around the hospital going into patients' rooms and saying, would you like music therapy?
So that's going to be my next question. How does care get initiated?
I work closely with the nursing staff in particular, and I sort of round with them. And I get a referral, just like a physical therapist or an occupational therapist will get a referral for a patient who has those needs. So I will round with either a charge nurse or nurses on the unit, and they will give me referrals. They'll say to me something like, Ray, I have a patient that's very, very anxious. I really don't want to give them any more medication, but I need to reduce their anxiety. Can you go in and work with them? Or it may be a psychosocial issue, like someone may have gotten a new diagnosis and they're here in the hospital and they're having trouble processing that. Maybe I can help with some music. So it's important for me also to know what's going on with the patient before I go in, because I'm addressing specific needs. So.
Yeah.
I think the nurses do a really great job. They really look forward to working with Ray. He was on spring break last week, and the nurses really felt that loss of his presence, because everybody asked me, so he's coming back next week, right? So they really have, we started out a few years ago with this program, and they really have embraced it and utilize it as a standard of care versus just a nice to have. And I think in particular in our ICU, they were probably some of the early adopters, as well as our oncology unit. Really saw the benefit of what Ray was doing from the beginning, wanting to utilize those non-pharm methods and, the holistic care that we as nurses are all taught in nursing school and we want to give our patients, really being able to offer a patient something as unique as this. And I think it really not only touches the patient, but the family as well, because oftentimes Ray will welcome the family in while he's doing what he's doing. And there's a fair amount of curiosity, particularly when we're working in ICU because our patients are so sick. The families often will request to be present, and Ray does a great job of including them. And I think they feel really touched to be a part of what he's doing, and it really means a lot.
Do you find that the music therapy that you are providing to the patients also kind of incidentally helps lower some stress for the staff on the units too? Because I remember when I was working in EMS in Boston, there would be music therapists, but also like just even piano players in the lobby. And I would walk in after like something crazy and be like, there's just this beautiful music in this one hospital. And I was like, this is just really nice, even for like the 15 seconds that I'm walking through here, to just take it down a notch for me, even though I'm not the intended target of this. Do you find that the staff feel that way at all?
I think so. I know, as I said last week when Ray wasn't here, I think the nurses, of course, were also missing having music therapy here. There are times when you will see them sort of congregate outside of the patient's room because they're listening and enjoying. And I think that there's, when you work in an acute care environment, you can feel a vibe, if you will, on certain units when things are very hectic, and you can feel the anxiety of the unit. And I do think that there is a secondary benefit to the nursing staff as well. That would be a really good study for us to do in the future, to study the secondhand benefits to the nursing staff and all staff really, because we do have a lot of providers here, particularly our intensivists, who have really embraced Ray and really enjoy having him and recommend him. So
to add to that, I think part of it is a lot of the times I'm getting referrals when nurses' hands are tied. So they don't know what to do because their patient's in pain and they cannot give them any more medication for 2 more hours.
Right.
Their hands are tied. Or, even the psychosocial issues. It's like the doctor was just in and maybe they said, unfortunately, we're going to have to suspend treatment because it's not working. And then the nurse's hands are tied. So a lot of the referrals I get are in those situations. And I think just having something that they can rely on to help in those situations may help relieve their anxiety and stress as well, because they're very caring for these patients. And I've also had a couple of the nurses on the unit tell me that when I go in to see their patients, they will just sit outside the room and do some charting. That way they can hear and kind of also take a break for themselves to just kind of, reset and refocus so they can go on with the rest of their day.
You're right. Just sometimes you feel like you have nothing to do. Like there's times when I'm like, I know I'm just in a holding pattern waiting for tests to come back, or there's no meds to be given. And we do have a problem. And I think that overprescribing of antibiotics is a big example of this, of we want to help people and it's not always the best intervention, but we want to give someone something to make them feel better in that moment. And so we do it, even though we shouldn't, but giving them something that can actually be evidence-based and help them in that moment right there with immediate gratification must be really rewarding for your clinical staff, and not being like, well, I really shouldn't give them that, extra med, even though it's a Tylenol or whatever, or God forbid, an opioid, because you want to just do something to help yourself in your own internal struggle. And the patients, don't always know what's best for them because that's not their job to know what's best for them. That's our job. So that's a great kind of intermediary because it is evidence-based. So tell me about the evidence. You guys did a study.
Sure. Yes. We did. So we started our research study in 2016. And it was around the time Ray and I had been working together for a while, and we started, noticing the benefits. And Ray was working on his master's degree, so he had to do some kind of project. So we started talking about research, and right away we thought, we want to do a study in the ICU. And the reason we wanted to do that is there really isn't much evidence for music therapy in the ICU specifically. There's some for other pockets of different environments, like oncology. There's been a number of studies. But we really felt like that patient population in particular could benefit. I mean, they're the sickest in the hospital.
Right.
Anxiety is always a big one there, as well as pain.
Yeah.
And so we really gravitated towards that environment. So the study we did, we enrolled 52 patients. And the patients we enrolled for this study, it wasn't ICU, but they had to be able to consent.
Right.
And that was for a number of factors. Ray was working on his master's, and we had sort of a time crunch, if you will. We needed to get the study done in a certain time frame. And in order to include patients on ventilators, then you have to have more nursing involvement in the study to actually assess the patient. And since Ray is not a nurse, he cannot use nursing tools to assess patients. So he can ask a patient on a scale of 1 to 10, what's your pain level? On the Likert scale, he can do that. But, he couldn't use the CPOT or the RAS or the other things we use in critical care. So we approached patients, since we are a community hospital, our unit, ICU is a 12-bed unit. We do have a Beacon Award for critical care excellence, which we are very proud of. And we enrolled patients who were able to sign the consent. So obviously these were not vented patients. And we have a mixed unit, since it's a 12-bed unit. The census, fluctuates with acuity like any place else. So there are times when we have 12 vented patients or 10 vented patients, and then there's times where we only have a few. One of the challenges that we encountered because we were doing this type of study is there hadn't been any other music therapy studies here at Inova. So we went to a full board IRB review when we submitted our protocol.
Which is the institutional review board that has to approve all studies.
Yes.
For any listeners that are not familiar with writing study proposals and that fun
stuff like that.
Part of science.
So much fun.
So Ray and I were called to come to the IRB to present our protocol and sort of answer the questions they had. That's what happens when you do a full board IRB review. So that is sort of atypical for this type of work because this is music therapy, right? We're not taking blood from patients. We're not giving them experimental medication. So it's a fairly low lower risk study. However, it's a study with a vulnerable patient population, which is ICU. These patients are sick. They were concerned that there might not be enough patients who could sign for themselves, which, amongst our 5 hospital system, we're a community hospital. So as I said, our census can vary a little more than maybe, say, at Fairfax, where all of their patients in general in ICUs might be on a ventilator. So some of ours may or may not. But they really had the most questions for Ray because we hadn't done a music therapy study before. The questions primarily were about like what we were doing, and we also offered 2 different interventions. So typically in research, you provide one intervention for all the patients and you measure how it works. In this study, we offered 2 different interventions, and that's really because we were trying to meet our patients' needs. Mm-hmm. So with music, you don't want to offer every patient country music because not every patient likes country music.
Yeah, that would raise my anxiety levels and be
mine
like,
as well.
Get out of here, guitar man.
Right.
Well, one of the so just to sort of touch on that. So first of all, what we were looking at was the effects of a music therapy intervention on vital signs, heart rate, respiratory rate, and oxygenation, as well as self-reported pain and anxiety.
So you have your quantifiable and your qualifiable.
So we would get
outcomes.
We would get those measurements, and then I would do a 30-minute music therapy session with the patient, and then we get those measurements again, and then we would compare pre and post. Yeah. So as far as the intervention goes, one of the things the IRB was wondering is why are you not playing the exact same music for every patient? It's like if we're doing a drug trial, you give them the same drug. Well, that's not how music therapy works. See,
that's a very scientist-based question.
But the whole point of a music therapy intervention is it's individualized to meet the individualized need of the patient in the moment. So what does that mean? Right? If the patient's very anxious, I keep going back to anxiety because everybody does have anxiety in the hospital. But the patients have a little say in how music therapy can work with them.
And I think that's really important too, is like in the place where you have no control, to have control over something, that is therapy in itself.
Yes, it absolutely. Yeah. So, I would assess where they were. Maybe they're really, really anxious. And I would say to them, okay, sounds like you're really anxious. There's a couple of things we can do here. So the first intervention, one is I could play some nice relaxing music or improvised music on the guitar. You can sort of close your eyes and I could talk you through maybe some breathing and some visualization. That's one possibility. Or maybe we can do something a little more song-based, where we find some songs that either speak to how you're feeling or songs that are very important to you. We can play those songs, we can sing them together, or you can listen to the words, and then we can talk about the songs afterwards. And then I would say, what do you think would be helpful for you right now? And they would tell me, and that's what we would do. And that is, like you said, with control and patients' sense of self, that's very important. And it gives them an immediate sense of control and sense of self. I don't know anyone else going into their room asking, I don't think the physical therapist goes in and says, so what would you like to do today?
Do you want to play soccer or do you want to do those weird leg exercises?
Yeah. So that is really what we had to explain to the IRB when we went there. And once we did, they got it and they were like, oh, that's kind of cool. And so that was the 2 different interventions that were offered.
Right. And amongst the 52 patients, they split themselves fairly evenly. So I think it was 28 in one group and 24 in the other. So it was about even.
With the intervention,
the 2 different interventions we offered. But what was interesting and what we found is that regardless of the intervention, both patient groups had statistically significant decreases in pain and anxiety and heart rate and respiratory rate. The only measurement that really wasn't impacted was SpO2.
Okay, well, that's good.
Yeah.
Although,
so we would want their oxygen levels to stay the same.
Or improve.
Or
but
improve,
but do anything in that regard.
Although I do think heart rate decreased more in the relaxation-based intervention, where they were closing their eyes and I was just playing the music and talking them through breathing, versus the song choice intervention. Because the song choice intervention, they were sort of more active in that. And even though their heart rate didn't decrease as much, their self-reported anxiety and pain, as Amanda said, did. Now, in the intervention with the relaxation experience, I think it was 12?
Yes.
12 patients fell asleep.
And,
I did not wake them up to ask them when
Yeah.
they're,
So
0
was
to
that
10.
calming for you?
Yeah, exactly.
Wake you up and
Because the nurses were like, "Do not wake my patient up."
Get
so
out of there.
we looked at that as a positive, obviously,
Right.
but that did pose some statistical challenge, and we did have a
Yeah, how do
statistician.
you-
So we had to do these various multiple
Imputations.
to
Yes.
kind of show that was a positive outcome. So
Yes.
that was a very interesting part post as we were writing this up and analyzing. So
That's interesting. You wouldn't think about that because you're like, oh, just numbers, but like, oh, they fell asleep and now they can't report, and now we don't have the data there.
Right.
But that's a really positive thing in the ICU of,
Yeah.
oh, I didn't give them Valium and now they're asleep.
Able to rest.
I gave them a guitar riff and now they're asleep, and that is so much better.
and from a
Right.
statistical standpoint, you can't just give them a 0.
No.
Right.
as a self-reported. I mean, we just don't know.
Right.
But so that's why they had to do these various different computations to figure out the statistical,
Right.
So
status.
where did you publish the study?
So it was published in the January 2019 edition of American Journal of Critical Care.
Okay. We will share the link to it on social media.
Sure. So, and just as Ray was saying, we did have our primary statistician, Dr. Golenberg, on this study, and she partnered with another statistician because of that specific situation, and they were able to, in their statistical language, make a reasonable deduction of what that patient's number would have been, and it was a very complex thing. But Ray and I sort of, that's kind of where we defer to the statistical experts on those types of things.
Right.
Yes.
Everyone is an expert in their specific field for a reason.
Exactly. And one of the things that we did, so going into this study, this was my first study as a principal investigator. I was fortunate, though, to work on a few other nursing research studies where I learned a lot and partnered with some nurse mentors of mine. And one of the things I learned in a previous study we did in our ICU using Healing Touch is when you use blood pressure as a measurement. If you use blood pressure as a measurement, it can be disruptive to the patient. It's a tight squeeze on their arm. Yeah. Unless you have an arterial line, which we don't always have on every patient in ICU, we have on some. So part of the reason in this study why we specifically didn't measure blood pressure was because we were looking to see if we could provide a relaxing or reduction in pain benefit, and we felt that would be disruptive to the patient to go ahead and squeeze their arm with that blood pressure cuff after we just relax them. So we specifically did not measure that because of other work that I had done where I observed that, and we talked about it when we did the study design, and that was why we didn't do it. So there was intention there when we were designing, because I partner with the nursing research team here at Inova, and I had learned from those other studies. So,
and I think it was important too. We didn't want to change anything we were doing just for research purposes. We wanted to do research on what we were actually doing every day.
Right.
So everything we were doing in this study, it was our general music therapy care here. We didn't change anything that we were doing specifically for the study. So, if a patient falls asleep, that's great. So that was very important to everyone involved. We really wanted to see if what we were specifically doing was working statistically. So
sure.
There was this great joke study that was released by the British Medical Journal last year about parachutes failed to show any significant difference in survival rates when jumping out of an airplane versus no parachutes. And then it goes, the study was conducted jumping from planes that are on the ground and not moving. And so it was basically, the point was studies have to be done, in the way that you would see them in clinical practice. A lot of times study environments don't replicate the real world. And so you have to kind of extrapolate your data based on that. And so that's a very important point, that it has to be how you would do it in clinical practice. So where are you guys going from here with it? Are you going to be doing any more studies? Are you going to be changing the way you practice at all with this?
The importance of this study, this was our pilot work, right? So we acknowledge, this was a single site study, and, there was some limitations to the study. Obviously, we've already spoken about them, but we needed to do this study to show that music therapy helps in an ICU, and we really didn't have much research on that. And some of the reasons are, there's challenges to working in an ICU environment. There's a lot of factors that can come up. challenges in enrolling patients and patients moving around. Unfortunately, sometimes patients dying. But we did decide after we did this study, we actually presented it at the ANCC conference in Denver, Colorado this past year. So Ray and I did a session there, which was fantastic. And we got to talk about the work we're doing as a magnet nursing hospital. So we're very proud of that. We wanted to do the next study on patients who are on the ventilator. That's the next step for us logically. We know there, again, isn't a lot of research on that patient population. Obviously, these are the sicker patients. So really, we don't know what the benefit is to these patients. We think and we learn as nurses that our patients can hear us. So we think that it'll benefit them. But we just really don't know. So we are in our second study right now, enrolling patients. And this study is really very different because it's a study for patients on the ventilator. We are doing a different intervention, one type of intervention versus offering choice because the patient can't really speak for themselves. Because these are patients on the ventilator, we're approaching what we call the legally authorized representative, the LAR, which is typically their spouse or their parent or their adult child, depending on their situation. So that poses some different challenges as well because you have to approach a family versus the patient directly.
Right.
But we started our study in November, so it's been a few months now. And this is also a randomized control trial. So unlike our previous study where everyone was getting the intervention, in this study, half of the enrollees will receive the music therapy intervention and half will get put in the control group, and they will receive usual ICU care during that time. So going back to what you were saying about letting the environment be what the environment is, we are not manipulating that at all. So if the patient is getting a central line during that 30-minute time frame, we note that, but we're not trying to dim the lights or make it calming, or we're not manipulating that. It's just whatever happens during that time. So it's going pretty well.
Yeah, and we'll compare the two groups to see if there is a bigger reduction in, and we're looking at pain and agitation in this case. So we can compare the two groups here to see if there's a bigger reduction in pain and agitation in the music therapy group. And we have, you can speak to this on the tools we're using to assess their pain and agitation and why we have nurses on the study team as well.
Yes, so this study, again, it's also a nursing-led study. We do have a few sub-investigators who are nurses who are helping me enroll the patients. And then we actually have 4 of our ICU nurses who are doing the data collection. And the reason we have nurses doing the data collection, unlike the previous study where Ray was doing the data collection, is because they're using validated tools that we use in ICU. So obviously it has to be a nurse that's doing the assessment. So we're using the CPOT, which is our validated pain scale for ICU. And then we're also using the RAS, which is our measure of agitation. So we're using those, and we're also tracking the same measurements as before. So heart rate, respiratory rate, SpO2, pain, agitation, and we are looking at their medications as well.
So like PRNs and stuff?
Some of these patients are on continuous strips, various vasopressors. So there's a lot going on with these patients and coordinating the session, but we are making it work.
Yeah.
That's really exciting.
And as far as I just want to touch a little bit quickly on the intervention that I'm doing in this case, because it's different with the patients on ventilators.
Yes.
So, I can't really speak with them to find out how they're feeling, what they want, what kind of music they like. So I work with them a little bit differently. So if someone's on a ventilator and oftentimes we think they're anxious or have a lot of anxiety or agitation, how do we know that? They can't tell us, but maybe their heart rate's really, really high.
Right.
So maybe their heart rate's like 120. So we know that's an indicator. So how can I work with that? So I was talking about why I use live music, meeting the patient where they are and then moving the music to another place. For me, that 120 is like a metronome. A metronome in music keeps the beat.
Yeah.
So I may start my music matching their heart rate. That's the tempo. Can I show you something? Can I show you on the guitar?
Yeah, sure. So the only thing is we can't play any copyrighted music.
No, I won't.
That's cool.
No copyrighted music. I'll making it up as I go, which is what I do anyway in there.
Right.
So, if their heart rate is high, it's 120, that's about this. So I'm going to start my tempo. And I'm watching the heart rate monitor, and It's called entrainment, meaning the rhythm of the music is entraining with their heart rate. And we'll just be together in the music for a little bit. And then what will happen is I will very slowly and gradually start reducing the tempo, making it a little bit slower. And then I may see the heart rate following now, because our tempos are matching. So that 120 now might be coming down to 115. And then we may go 30 minutes. Then the tempo ends up being something like this. And when we end, here's my tempo, and their heart rate might be at a nice resting 85. So that's why we use live music in the moment. And that's how we can work with patients on ventilators.
That's fantastic.
Yeah. Now, sometimes
it's so much better to record it live, too.
And sometimes I might incorporate songs or music that they like, because I may find out from someone's daughter that they love Elvis. Mm-hmm. So I may incorporate some Elvis music into what I'm doing, or they may love Frank Sinatra, or they may love country music, or they may like the Foo Fighters. Yeah. So I can incorporate some of that.
Some Ozzy.
Yeah. Hey, everybody likes what they like, and it's important. Yeah. So I will incorporate some of that. So that's how we can work with patients on a ventilator.
That's so cool. And obviously you're very, very talented to be able to do that and to improvise on the spot and just kind of match their heart rate. I mean, that is a clinical skill to do that.
Well, we call it clinical musicianship. So when we're studying, in school, that's part of what we're learning. We're learning clinical musicianship. And that's why a music therapist who's trained is very different than just having a musician coming in and then playing nice music for patients, which is great. And I'm not saying we shouldn't have more of that, but that's not what music therapy is. Music therapy is a clinical approach.
That makes sense. And then as you were doing it, then it makes it clear. You need to kind of see it to experience it. So do you have any great stories of patients responding to it?
We don't want to share too much about the current study yet, just since we're in the midst of it. Now, Ray has so many fantastic stories about the work he does here in general, and I know he has some selected.
Yeah. So we talked a lot about the very technical aspect of what we're doing.
Give me the feel-good stuff.
Right. So also, this is an arts-based therapy, and the aesthetics and the beauty of the music is very important. So regardless of what I'm working on, there's always an emotional element that comes into play, and we work with emotions. And now I'm just going to switch over to oncology, where I also do a lot of work. And in that unit, it becomes more psychosocial. And I'm working more on, coping, emotional support with music.
Yeah, I imagine.
So I have a little story here of a woman I worked with not too long ago here in the oncology unit that I would like to share.
Yeah.
So this woman, she had come here to the unit because she had a new cancer diagnosis. The thing with her was, about 2 years ago, she had a different cancer diagnosis and had gone through treatment, chemotherapy, radiation therapy. And then after that was completed, she got a completely different new cancer diagnosis and was now back in the hospital.
Oh, no.
So, she was feeling very defeated.
Yeah, of course.
And very down. And again, when the nurses asked me to go visit with her, it was for that reason. She was feeling really defeated, really down. So when I went in, I just went in to meet her, and she told me her story. She told me this story about, what she had gone through, and now here she was with a new diagnosis. So I just let her talk a little bit, and I listened to her. And then finally, I redirected the conversation a little bit to music, and just talking about, how we could maybe use music to help in some small way here. So we talked about things like resetting, refocusing, refocusing what's going on, taking small steps because everything seemed like so daunting.
And this was inpatient?
Inpatient.
Okay.
Inpatient. Yeah. So the first thing we came up with was, okay, what's the first thing we have to work on here? And she said, well, it looks like I'm going to have surgery. Mm-hmm. So I thought, okay, well, let's think about, that's the first step, preparing for surgery. And she had surgery on her previous diagnosis as well. So after we talked a little bit and we were kind of a little rapport going there, she told me a story that she and I had actually met before in this hospital a couple years earlier when her dad was here. And her dad was very sick and he was at the end of life. And I had gone in, I was asked to go in to bring some music in for him and his family as he was preparing to transition. So that's another area where we can use music to help. So she told me this story, how I came in and he loved Frank Sinatra. He was a huge Frank Sinatra fan. So I was playing some Frank Sinatra songs for him. And as she was telling me the story, I started to remember the situation because something really, really cool happened. I started playing the song The Way You Look Tonight, which is a Frank Sinatra song. And as I did, he kind of opened his eyes and he kind of lit up a little bit. And somebody said, oh, that's his favorite song. Aww. So he kind of sat up a little bit in bed. And then this woman, who is his daughter, who I was talking with now, walked over to the bed and took his hands and started dancing with him. And they were doing this little dance. And it was beautiful, emotional. There was a lot of emotion in the room, as there often is. And after we were done, she pulls me aside and she says, I am not yet married. I always thought that would be the dance we would dance to, the father-daughter dance at my wedding. And I said, well, you got to have that dance now. So it was a very poignant moment for her as well as for him. So she reminded me of that. And I was like, oh my gosh, I totally remember. I remembered that. So we had a real connection now, a real connection through music. Right. So then I said, all right, let's get back to talking about your situation. And I said, tell me, are there any songs from your past that have meaning for you? Anything? And she said, yeah, actually, there's this Kenny Loggins song. It's called This Is It. And she said, I always liked that song. And I recently heard a podcast where Kenny Loggins wrote that song for his father, who was going through cancer treatment. And he wanted a positive song that he wanted him to fight. He wanted it to be a fight song. So I said to her, okay. So what I did, the first thing I did was I actually pulled out my iPad and we listened to a recording of it. And as we were listening to it, I said, let's listen to the lyrics and see what's going on here. And then after we listened to it, I said, wow, these lyrics are really poignant for you right now. So I said, would you sing it with me? So I got the lyrics for her and we sang it together. And it has very strong, it's like, I want to fight, I want to fight. And after we were done, I said, this is the perfect song for you. This is your fight song. And she said, yes. It is my fight song. And I said, whenever you're feeling down or feeling like you can't go on, just listen to it. And I printed up the lyrics for her. And then she said, okay, that sounds like a good idea. And as I was leaving, she said, okay, first step, get through surgery. And I thought, wow, the thing I thought I saw a little bit of that I didn't see when I walked in the room was a teeny little bit of hope.
Yeah.
And it was like because of this song that we found together in our conversation. And so I printed the lyrics for her and she had this little bit of hope and a little smile on her face when I left. And here it's like we have connections with songs too, like meaningful songs in our life. Yeah. And we can bring that into a situation like this. When the stakes are high, it's like we have these songs and this music. So she was here for a couple more days and I would stop in and she would show me her lyrics and she would smile. So that's just a little story of how we can really use the emotional elements that music and songs can bring. And every situation is unique and unto itself. It's like meeting the patient where they are and what do they need in this moment. And what she needed a fight song. So we gave her a fight song.
Yeah.
So
that's beautiful. I think all of us were sitting here tearing up as you were telling that story. This podcast doesn't have a lot of happy, feel-good moments on it. Usually people are like telling about really traumatic stories from EMS or something. So I'm like, this is not a comedy podcast, it's not a feel-good podcast. So it was really nice to have feel-good stories for once. So thank you. Is there anything else you guys want to talk about what you do here at all before we wrap up?
The only other thing I was going to mention about the study that we're doing right now, which is really interesting, is when we built the study, we had a thought that the patients' families who, we come back in and say, okay, they were put in the control group or they were put in the intervention group. I would say the overwhelming majority of the families who are consenting for their loved one to be in the study want the patient to still receive music therapy, even if they're put in the control group. And we built that into our study protocol because we felt that it's become a standard of our care here, and we did not want to deprive patients. We wanted to do the study study as an RCT to make it a stronger study, but we did not want to deprive anyone of receiving music if they wanted to. So most of the time, even if our patients, they get put in that control group, their family still wants them to receive music therapy. And I think they really, in general, patients, family members, when they get to be there, they really look forward to it. It's really not just the patient that's experiencing it. It's sort of, Ray has like almost an entourage at times of people in the room. And so it really goes beyond just the patient. It's really like a whole family experience, or like you said, maybe the nurse is benefiting, maybe the physician's benefiting. So it really kind of speaks to what you're trying to do in healthcare, right? Which is meeting patients' unique needs, really speaking to an individual and treating an individual and not a disease. And
well, anytime there's caregivers in the room and I'm working with a patient, it becomes just as much for them as it does for the patient. Sometimes even more so, because they don't have a whole lot of or many resources for themselves while they're here. They're trying to be, the rock and be here for this person, but they're going through a lot of stuff too. And it is amazing. Yeah. It is amazing to me how much, just adding a musical element just brings out emotion. And I will see caregivers just sort of have a cathartic release. And I'll say to them, this is good. You're holding all that in. You need to sometimes just get this out as well. So it's always about everyone in the room. So, like Amanda was saying, and just to clarify, so we do the study and we get all the readings, and then after the fact, they'll still be able to have music therapy.
I was going to say it's just at a separate time.
Yeah, just at a separate time after the fact. We don't want to deny people a service here. Going back to our research study, we don't want to deny something for someone because they're not in the intervention group.
Right.
If that makes sense.
Yeah. And you mentioned for the caregivers as well, but also in primary care, I'm always looking for like patients to say like some little nugget of something that I can kind of pull on a thread to get to know them a little bit better and to help build that connection for individualized care. And so, oh, you're going on vacation this weekend. Where are you going? What do you like to do? How can I know you better as a person? Because in primary care, we have very extended relationships. But of course, in the ICU, they may be here for a long time as well. And so if a nurse is maybe watching you do music therapy, they may know that patient much better because they found out what they like as far as their music or what kind of personality that patient gets. And they're seeing them in a different light. And that can be really helpful for the nursing care to go, oh, I like Kenny Loggins' music too. I saw him in concert once. And all those little small talk conversations that you can do while you're changing a PICC line dressing or you're doing all these things that are just not talking about medical care. It's so important for nursing and providers and all these other things that there's all these other secondhand benefits that you can get from it.
Right. Absolutely. I think the nursing staff does a really good job of addressing the patient's unique needs, and using music therapy is really, just complemented our practice. And I really think it is helping, and that's another thing we can study too, is long-term recovery. And maybe in the future, we might be looking into that as well. But I think Ray really, there are certain patients that he sees throughout their hospitalization, and that really speaks to the connection that he's able to build with the patient and the family. And it's just really powerful. So
that's so awesome. It's wonderful that you guys are doing this here and that you seem to be really well supported by the hospital to do it. I mean, you invited me here to talk about it. So that's a testament to it in itself. And Ray, I wish you would hang out in my waiting room and play music for patients. It would probably make all of us a lot better, make our lives a lot easier. So thank you guys so much for taking the time out of your day to speak with me about music therapy and everything you do here at Inova Loudoun.
Thank you. Thanks for having us.
All right, guys, I hope you enjoyed that special episode. And thank you so much to everyone at Inova Loudoun for inviting me out there, specifically Renee. Thank you for coordinating everything and allowing me to come out there and work with Amanda and Ray. You guys were really fantastic. It was a great opportunity for the podcast, and I'm so grateful. Anyone that wants to reach out to me, you can do so through all of our social media accounts. It is Antidotes Stories in Medicine Podcast on Facebook, Antidotes Podcast on Instagram. Twitter is Antidotes Pod. My Twitter is Christine the NP. And of course, you can always send me an email at antidotespodcast@gmail.com. And thank you, as always, to Peter Hopkins, our wonderful musician who made our custom music. So everybody, enjoy your accomplishments. Congratulations to the new grads. Everyone that's been in the field a while, be nice to the new grads. Remember when you were new too, please. And I will see you next time.